Welcome to another podcast from AMCAIM, the American College of Artificial Intelligence and Medicine. I'm Dr. Mel Spiceman, President.
And I'm Dr. Ann Slesoritis, the Executive Vice President. Our mission is to explore the rapidly evolving intersection of AI and healthcare. Whether you're a physician, healthcare leader, researcher, student, or simply curious about the future of medicine, we're glad you're here. Thank you for joining us, and let's begin today's conversation.
Today's episode of the AMCAIM podcast, we are really delighted to introduce John Hanna, MD. Dr. Hanna did his internal medicine residency at Rochester Regional Health. Currently, he serves as the Associate Chief Health Information Officer at ECU Health, and he's also an affiliate faculty member at the Brody School of Medicine, East Carolina University. And he will be giving a presentation this year at our scientific session on AI and infectious disease. Welcome, John.
Okay, welcome, Dr. John. And we would love to hear a little bit about your journey. So what initially drew you to medicine and infectious diseases, and how did that path eventually lead you into the world of artificial intelligence?
Thank you for having me. I was an internal medicine resident at Rochester Regional Hospital where COVID-19 hit. Now, I wish to say that that's why I ended up in infectious diseases. I just happened to be one of these people who like problem solving. And as y'all know, nobody loves problem solving more than ID docs. So pretty quickly, I planned my journey as an ID doc. Then COVID hit after I already matched in my fellowship at UT Southwestern. And when COVID hit, during the time of uncertainty of COVID-19, I helped the system with the COVID registries that helped out with preparedness and with research. And I found myself falling in love in data. So when I fell in love with data, I started learning about that new field called clinical informatics, which traditionally is all about the CHIO 1.0 that is support HR optimization. And then it was evolving at that time to the CHIO 2.0 and 3.0 that also focus a lot about using data-driven data to drive decisions in healthcare and to support transformation. And that data, at the time of the AI revolution, when I was at UT Southwestern during my ID fellowship, the data love all become related to artificial intelligence at that time. Now, I was fortunate enough that during my integrated training experience for infectious diseases with clinical informatics, I had a mentor who petitioned the board for me to become the first integrated clinical informatics adult infectious diseases fellow in the country. COVID-19 at that time didn't make it really hard to justify why we need more ID informaticians. But from that time on, my love to ID for problem solving turned into my love to problem solving at the system living, trying to help with real world data for answering questions, and then AI development, deployment, implementation, and life cycle. And after my graduation, I joined ECU Health here as an associate CHIO to support our AI maturity journey, digital health transformation, and traditional clinical informatics work as well.
Wow, what an exciting journey. And medicine is lucky that you love data. So we always enjoy hearing the backstory behind the work, because it gives us a much better understanding of what drives someone's passion and interest. Thank you for sharing that.
John, in your recent paper where you describe that for infectious disease, AI is the ultimate stress test, you refer to the ID physician as an orchestrator. Why do you believe that ID represents one of the most difficult environments for AI to succeed?
Well, I do think ID is one of the realest stress tests for clinical AI. ID consults are usually not single data point consults. So we almost never make decisions based on one lab, one culture result, one symptom, or one imaging finding, for example. We're constantly integrating the organisms, the host, the patient's clinical trajectory. That's what makes ID fascinating, but it also what makes it, I think, going to be a good test for AI. Because a positive culture doesn't always, for us, mean infection. A fever doesn't always mean infection. And a negative culture doesn't always mean there was no infection. Everything depends on context and ID. ID is really very rich in context. That's where I think the idea of ID clinician as an orchestrator becomes important. Because ID clinicians today already orchestrate care while wearing many different hats in the hospital. Clinician, diagnostician, steward, infection preventionist, public health partner, consultant, educator, researcher, and frequently system thinkers. And as we move into the agentic era, I think that orchestration role becomes even more important because ID clinicians will either be passive adopters of AI technology developed by technologists or other clinicians, or active orchestrators of these systems. And I personally think we should help shape what these systems see, how they reason, and what they are allowed to automate once they touch our ID workflows. So if you think about the design of an agentic system, it perceives data, and I'll call that the perception layer. It reasons over context based on different goals, and I'll call that the cognitive layer. And then it can take action through the action layer. At the perception layer, we need to help define what rich clinical context should be ingested that would be at least close enough to the rich context ID docs usually are proud of using. That's usually beyond labs, cultures, for example, incorporating the host risk factors, social determinant of health, very rich social history, prior antimicrobial exposure, local epidemiology, and the clinical story around the patient. And at the cognitive layer, we need to decide which forms of reasoning are appropriate for AI assistance and what tools it should have access to, which decisions requires a clinical judgment of a clinician, ID clinician in the loop. And at the action layer, we need to decide what can be safely automated, what should be nudged, and what must remain clinician-led. So as I think about AI and ID, I think about a future where us ID clinicians are helping orchestrate not only the clinical care, but the context, the reasoning, the workflow, the guardrails around assisting agentic systems.
Great, John. I do agree that the cutting edge issue in 2026 is focusing on AI agents, and it's fantastic that you're developing and working around this idea of an AI agent that's an ID assistant or consultant that can do the multi-step process. So really bravo for you for tackling that. This is like the most important issue right now in AI.
Yes. So I wanted to ask you about sepsis. So sepsis has been one of the earliest and most visible applications of AI in healthcare, yet it also has proven to be one of the most difficult areas to demonstrate consistent clinical benefit. But based on the latest studies, what can you share with us about both the promise and limitations of AI in sepsis care?
Absolutely. Sepsis is a great example because it shows both the promise and the frustration that the people implementing AI face across a complex problem like sepsis. On one hand, sepsis is exactly the kind of problem where AI sounds very attractive, it's common enough to matter, high stakes, time sensitive, and the signal is often distributed in many places in the EHR. The recent literature shows that AI in sepsis is moving in a few important directions now. First, we see multi-center validation studies that reminds us to be careful if we implement early detection of sepsis predictive models as point solutions in care. An example of that is the recent publication in JAMA Network by Juan Rital. In their multi-center perspective validation of the updated EPIC predictive model, they highlight that performance can vary across health systems, and even a strong model statistically doesn't really automatically translate into a usable clinical value everywhere. Second, we started seeing experimentation with models that use richer clinical context, not just structured EHR data. So for example, Composer LLM from UCSD using clinical notes added additional information for early sepsis prediction than just the structured EHR data. This data is often missing from the structured data that feeds the traditional predictive models. And it seems that such approach has the potential to improve the past predictive value of sepsis flags. Third, we're seeing AI being used not only for bedside prediction, but also for quality measure abstraction. So the same UCSD group studied AI-enabled abstraction for step 1 quality measures, and the ED clinician who had near real-time abstracted cases available to them by AI had better bundle compliance overall compared to those who didn't. So I think the main lesson from sepsis literature is that sepsis prediction is only the beginning, and we've been experimenting with that for years now. But the real question now is whether the prediction is connected to a workflow that clinicians trust, the teams can act on without alert fatigue, and the health system can continue to monitor for continuous learning.
So excellent points. Just continuing on with that paper, the multi-center prospective validation in JAMA that you mentioned, the model achieved an AUC of 0.83 to 0.86 for sepsis prediction. But what do you think has to happen for us to achieve these reasonably good prediction metrics to make a real impact, say on maybe mortality?
Yeah.
How do we get to that?
Absolutely. So this is layered. First,
Yes,
this is one of the most important lessons from sepsis predictive models, that a good algorithm doesn't automatically create clinical value. Part of the issue is what I will call here the prevalence trap. So sepsis is high stakes, not uncommon, but actionable sepsis deterioration is still relatively rare across all the AI predictions that are produced multiple times across different time horizons in the same encounter for all ED and inpatient encounters in a system. And when every score exceeding a set threshold is flagged as an alert for a clinician and surface as an interrupted alert, that threshold usually is tuned to prioritize sensitivity, but it often results in numerous false positives. That's where metrics can become really misleading for just the model performance. We may look at an AOR with C and say, this model discriminates really well, but clinicians experience the model directly through alerts, experiencing the positive predictive value or the false positives, the timing, the burden, and whether the recommendation makes sense in the moment. So the real question here becomes not only is the model accurate, but is this alert actionable at this threshold for this team in this workflow with the capacity to respond? If the answer is no, then even a strong model like the one in this paper can become noise. It can create alert fatigue, reduce trust, trigger unnecessary workups, or contribute to unnecessary antibiotics. In the informatics lesson, we learn the hard way every day. Once clinicians lose trust in the system, it becomes very difficult to regain it. This is also why studies like Heracles are interesting, which is a study from Switzerland. Heracles was not just a model, it was an AI-powered learning health system study around sepsis detection and quality of care. And the distinction here matters because it reminds us that the intervention is not only the algorithm. The intervention is the algorithm embedded in the workflow, the clinical pathway, the feedback loop, the quality infrastructure, and the people responsible for acting on it. So the prevalence trap is the first challenge, but another challenge is attribution. Even if outcomes improve after deploying a sepsis model, it's really difficult to know whether that improvement came from the model itself, the workflow redesign, the ongoing education, staffing, sepsis governance, quality improvement, or all of those together, because in a real clinical setting, the model is rarely the only intervention. That's why in our recently published Beyond the Model report at ACI, as we described our lessons learned monitoring predictive models across diverse clinical workflows in the lenses of people, process, and technology, we shared that we need to move beyond asking whether the model works in isolation. We need to ask whether the model is part of a functional clinical system that connects the problem measure to the ground truth prevalence, to the model performance, to the tune threshold, to the workflow. And the usability of this workflow layer is also the most important element that directly correspond to AI adoption. So as the prevalence trap is not just a statistical concept, it's implementation trap that directly affect usability. That's why it affects adoption. And this reminds us that rare event prediction in medicine has to be judged by actionability and had to be linked to the outcome it's trying to improve, like mortality.
Great. John, Ann and I are hospitalists, and as you know, 1 in every 3 deaths in the hospital worldwide are from sepsis. So really, this is in the inpatient setting, this is one of the most important problems to solve. And up until recently, we haven't really seen the kind of innovative, successful solutions that you're describing. And I really feel, after hearing your comments, that we're at a real tipping point where we're going to start to see AI actually make a major impact on sepsis. So thanks for the work you're doing to test it and deploy it in a workflow that's meaningful, that tries to limit alert fatigue. That's really amazing. Now, when we think about sepsis, we think about the triggers. For example, pneumonia, skin and soft tissue infections. However, there's also hospital-acquired infections, surgical site infections, central line infections, C. diff. In a recent paper entitled Using Generative AI for Healthcare-Associated Infection Surveillance from the Journal of Clinical Infectious Disease 2026, the authors suggest that generative AI can assist in the surveillance of these healthcare-associated infections. Can you comment on their potential to improve surveillance and prevention of infections?
Absolutely. So healthcare-associated infections are exactly the kind of outcome that health systems care deeply about, and hospitalists. Surgical site infection, chaotic eclampsia, C. diff, you name it. These events are harmful to the patient, the hospital, and expensive and reportable and central to patient safety. It makes sense that people would want to use AI to predict them, and surveillance as well should be supported by AI. But the same challenge, I think, shows up again here, because many HAI events are rare. And that means that they face the same prevalence mathematics we see in sepsis. A model can perform well statistically in terms of discrimination and still generates a large number of false positives. And for infection prevention teams, false positives are not just a statistical problem, because that turns into real work for them: more short reviews, more surveillance noise, more time spent adjudicating possible cases, and potentially less time focused on prevention activities. That's why I think we have to be careful about how we define success for AI for predicting HAIs, because the goal shouldn't be simply just to flag more possible infection. The goal should be to help infection prevention teams to more focus attention where it's most likely to prevent harm, reduce manual burden, improve outbreak detection, or support more timely intervention. So yes, we are seeing important work in this space. And some of that work, I can share other examples too, like Augustinho with colleagues from Switzerland studied semi-automated surveillance of surgical site infection using machine learning and rule-based classification models with an AUROC all the way up to 97%. And they link it to try to reduce workload and have success of 90% or more of workload reduction. Another example is Tang et al., who looked at guiding C. diff infection prevention efforts with AI, but was not associated with a significant reduction in the already low CDI incidence rate. That was at Michigan Medicine. And when we look in the literature beyond the HAI prediction, Sunderman et al. Showed that potential clinical and economic impact of real-time genomic surveillance for outbreak detection and control at UPMC Presbyterian Hospital. Also, a recent review at CID by Morgan et al. Highlighted that multiple recent small studies of simulated patients and retrospective studies of patient records have found GenAI has the potential to isolate individual criteria for HAI and make HAI determinations, which with accuracy similar to that of human expert, which I think the study you just cited. But for widespread adoption, I think GenAI HAI detection must be validated in a safe, effective setting in a prospective clinical studies to start to link it to the workflow and the outcome that actually we will measure to say, yes, it's reducing burden over time, or it's actually improving surveillance.
Okay, that was really insightful. Thank you for that. I wanted to go back to the agent for a minute. So regarding the raw data trap, where models can learn digital footprints in healthcare delivery rather than the patient's actual disease. So in the paper from Nature 2026, it was entitled Towards Autonomous Medical AI Agents. The agent they referred to, MIRA, MIRA, and that stood for Medical Intelligence for Reasoning Action. The model, it gathers information, reasons, takes action, and continually readdresses new information, like a physician. But I wanted you to just speculate on something and just tell us, where do you see these agents fitting into our workflow in the next 5 years?
Well, I think it would be really arrogant if I can tell what happens in 5 years from now. I'd say though
It
that
can't be wrong whatever you say, because we don't know. So just in your opinion.
yeah, I think these studies are really promising. But we can't forget that these studies are using artifacts that are, whether it's synthetic or HR data that's de-identified. And this is one of the biggest challenges in clinical AI implementation, that development happen with such data. And then once it faces the clinical reality, it doesn't really have the same outcome that was anticipated. The HR captures many useful elements, but it often captures artifacts of care rather than the full clinical reality that's lived encounter between the patient and the clinician. So, for example, it captures the culture, order, and the results, since this is about AI and ID. It captures the antibiotic order and administration, the fever curve based on point temperature checks, the SOAP notes drafted by clinicians from their own perspective after interpreting their lived clinical encounter, and the discrete diagnosis codes linked to these encounters. All of that is in the EHR. All of this data is available to AI to see. But it may not capture clearly why the culture was ordered, whether the patient looked toxic at the bedside, whether source control was thought to be achieved in the clinician mind at the time they wrote the note, whether the wound smelled infected, whether the clinician was worried or just being cautious, or whether the family gave a key exposure history that never made it into the HR data. And an ID is a context matter tremendously. A positive blood culture may be true bacteremia, maybe contamination, maybe colonization. A negative culture may simply mean antibiotics were given before cultures were collected. And when we see a broad spectrum antibiotic order on a patient as ID clinician, for us it may reflect, or we may think in our mind, but we don't really see it in the chart, that may be through risk, clinician anxiety, local habit, diagnostic uncertainty. And what we're thinking, if it's not in the chart and the AI can see, it would not be able to function in the same reasoning we do. So the raw data trap is that assumption that because data exists in the HR and the AI can see it during training or during the inference, that these EHR artifacts are a good reflection of the lived encounter. And this assumption we really have to challenge, because they are not. They are signals filtered through human behavior, documentation patterns, ordering habits, local workflows, and operational constraints related to how much time they have to really document that encounter with every single word that we're saying that. So when I see publications that use such contextual data that is constrained context and show a potential for autonomous AI, I always just take it with a grain of salt.
Okay. So how do we get that information into the chart if the agent is just using the EHR? The stuff that happens at the bedside. How do we get it there?
I think that's a great question, because now we have richer data that we are using in different AI tools. These richer data are ambient data, for example, like ambient listening that turn into a transcript, or ambient vision that is ongoing stream to monitor patients that are at risk. But in order to actually use this responsibly to train AI or to inference on it, we really have to navigate well privacy for the patient, because that comes first, regulations, how to use this data in a HIPAA compliant format, And we have to center it around the experience for the patient that will be comfortable enough that such data is being used to help them along the way without crossing their privacy.
Great. We're going to shift gears to antibiotic stewardship. Now, I mentioned, when working in a hospital setting, oftentimes it's the emergency physician that gives the first dose of antibiotics, as it should be, because, time is critical. But they frequently pick a very broad combination of antibiotics. And I'll just share with you that then the intern or resident writing the admitting order, as you know, they tend to just put down whatever the emergency attending put down. And we're in this mode where a very broad spectrum antibiotics have been given and then continued. What we're wondering is regarding antimicrobial stewardship, the teams already spend a lot of time after that point reviewing the EHR data, performing chart audits, providing feedback on antibiotic use. Has AI helped limit the inappropriate use of broad-spectrum antibiotics?
That's a great question. So unlike things that we talked about earlier, that workflows that have constrained context in the EHR when the data is used for AI, most of the workflows for antimicrobial stewardship already use the digitized data in the EHR. So the reason I mentioned earlier is that stewardship teams already work through many of the same digital artifacts that AI can see. Antibiotic orders, microbiology results, susceptibility results, allergies, renal function, prior cultures, local resistance, that doesn't usually mean that this data is perfect in the EHR, but that data is good enough that because they use it today to reason and reach out to the clinicians for audit and feedback. So probably today, if AI can see it, AI can start reason over that data and help with some assistance in that workflow. So thinking about what data is available for the workflow, what is automatable, automation ready, we have to consider some studies in the literature that already have proved some of the benefits. So for example, the INSPIRE trials. Recently published INSPIRE 3 and 4 studies showed that workflow embedded antibiotic decision support can reduce broad spectrum antibiotic use without worsening safety outcomes. And that was for SSTI and abdominal infection. That's a good example of where AI can help with the big guns and answer these questions: which patients truly need broader spectrum therapy and which patients can safely avoid it. And that's one of the most important stewardship decisions. But I would still be careful not to oversell it, because AI is not still in a place today where it can replace stewardship judgment, but antibiotic decision is still dependent on syndrome, source control, and severity of illness, goals of care. And our stewardship team frequently reach back and forth to talk with clinicians to clarify bedside events that they can't see while they're giving that audit and feedback. So I think really the value of AI here is that it can help standardize, prioritize digital evidence, reduce unnecessary broad spectrum use, surface patients who need attention, or provide real-time order prompts like the interventions and INSPIRE study.
Yeah, great. For my thought is that in the workflow, it should be integrated at the emergency room level, like when the first dose is ordered, not up on the medical floors, because that's, what happens in the ER is what gets continued. And often ID isn't necessarily consulted on every case. And so if we're really going to do good stewardship, it has to start at time zero when the first dose is ordered. But building on your ideas, what happens with infections in which some of the important information is not fully digitized? For example, wound infections, physicians rely on the appearance of the wound, the drainage, the odor, and the overall bedside impression. These aren't in the electronic record. So how do we build an effective AI system where some of these data that you would only get at the bedside are very hard to capture digitally?
This is a great contrast with the example we just talked about for antimicrobial stewardship, because now we're talking about context that's just partially available. So with the stewardship, a lot of the work already happens through digital artifacts, as we discussed, but wound infection reminds us that not all data are fully digitized. Wound care is partially visual. And yes, computer vision has a natural rule here, but studies on AI models trained on wound images, yes, showed potential help by identifying concerning feature, tracking wound healing over time, supporting remote monitoring, and potentially providing a more consistent second opinion. But it hasn't yet became as good as a wound specialist. So that could be especially useful in similar like AI in home health, rural care, long-term care, or settings where wound specialists are not immediately available to try to actually bridge the gap a little bit. But wound infection assessment is not only visual. Clinicians also use smell, as you shared, drainage, quality, warmth, tissue texture, tenderness, pain, surrounding erythema, and the overall clinical context. Some of these signals are really hard to capture in a photograph or EHR artifact, and many are not captured at all anywhere till actually a wound specialist start documenting it in the format that it should be documented in the EHR, and it's still categorized based on the limits of words we can put in place. So I think AI wound space is promising, but it also illustrates the limits of current digitization. That's why I see Wound AI as an example of both opportunity and caution. And it can help extend the expertise, standardized assessment where access is limited, but it also reminds us that AI will be strongest when we're honest about what data it can see, what context it still requires bedside human judgment.
Great. So what I'm taking away, and I think this is such a cool idea, is that the missing data, which is at the bedside, we could capture if we do ambient listening at the bedside and computer vision at the bedside.
Yes.
And that would solve it. Because right now in the outpatient setting, there's ambient listening everywhere, but not in the patient's inpatient room. So if we just added in bedside documentation of both the conversation and video data, like we really could get a bedside data.
That's what I'm actually thinking about as you're speaking. Computer vision, even when they're doing the home health, and people are going to the home and viewing everything. They don't have to write it down. Well, they'll have to just use the ambient listening for the note, but actually the visualization, and that would be amazing. That would bridge some of the gap here.
So what I'm hearing is do like a vision language model. That's what you're basically describing.
Are you working on that yet?
Well, again, it goes back to really patient privacy, regulations, HIPAA, how we can do that safely. There are multiple articles that are published about how many health systems have to actually delete the transcript, not even just like the audio. The audio is frequently living with the vendor, and these transcripts have to be deleted because we have to respect our patient privacy and other things. So there's a lot of things that we have to figure out first before we're able to use any of that for any AI learning. But also, I would say that may be just the first step, because think about telehealth. And when you have a telehealth visit with a patient, then next time you see the patient in person, you always have that feeling, oh, I thought you're a little bit taller or a little bit shorter, or the rich lived encounters still have a lot of signals and a lot of senses that we use as human that still may be missing from video or audio streams. So I think ambient technology is great if we figure out all the regulations and the privacy and how we can do that safely for our patients. It would be great to use that type of rich data. But even with that, I think there are more layers that will have to come to get that lived encounter status very close to what the AI can see.
Yes, very, very well said. And I like how you describe the actual patient interaction and the respect that you have for that. So thank you for that. And I'd like to switch gears just a little bit. And as we zoom out to a global perspective, many rural and underserved communities lack the digital infrastructure that exists in large urban academic centers. So how do we ensure that AI on infectious diseases extends its expertise to these communities and helps narrow rather than unintentionally widen existing healthcare gaps?
Well, This is such an important question. Thank you for asking it because AI could either narrow these gaps in care or widen them, similar to many previous digitization that happened. So on the optimistic side, I see AI has real potential to extend expertise. There is a huge shortage in ID, and in rural underserved settings, patients may have less access to ID specialists, antimicrobial stewardship resources, infection prevention infrastructure, advanced diagnostics, or timely public health surveillance. But I think if designed well, AI could help with triage, antibiotic guidance, communication, outbreak forecasting, things that are rarely happening like prep engagement, remote monitoring, and access to AI assisted specialist level reasoning. But in general, that type of value only happens if these tools are built for the settings where they are supposed to work. So a model trained mostly on data from high-resource urban academic centers may not generalize to a rural hospital like what we've seen in the literature. And the epidemiology may be different. The available diagnostics may be different. Microbiology turnaround time in these settings may be different. Staffing and transfer patterns may be different. And local resistant patterns is usually unique. Even the HR data may look different because documentation, access, care pathways are different. So the equity issue is not only whether the model treats different demographic groups fairly, but it also whether the model understands different care realities because it trained inside these realities. And in rural settings, for example, an antimicrobial stewardship recommendation may be extremely valuable where ID expertise is limited, but only if it respects the local formulary, the local resistance, the transfer realities of that place, and the available staffing that's usually shortage. Globally, the same idea applies. And AI can't simply be exported from high resource settings into lower resource settings and assume that it will work automatically. It really needs local validation, local governance, and local clinical leadership. So for AI to improve equity across different populations, we need inclusive digitization, that digitizing become an option everywhere to make the data available and fully represented from all access so I can see it. Community engagement, mobile and low resource friendly tools that are easy to deploy everywhere, and local tuning and rural and global representation in training and validation data. And if we can do that, especially across some of our most vulnerable populations, AI and ID settings could become not only just a technology story, but more of an equity story. It's almost unbiasing AI at the source by making all the data represented through accessing and digital enablement.
Wow, that's amazing. So, as a nonprofit professional society, we're committed to this idea of AI for good, and we have a real global presence with members throughout the globe. And we don't only reach out to the US, we reach out and speak all over the world, both live and virtually. And the projects that really excite us are what you just described, where you could potentially provide care to parts of the world where patients may not have access to a specialist. So, love the vision that you have for deploying AI globally to improve the care of everyone in the world. Uh, as we close the podcast today, we finish with what we call some fun facts. And so we're not talking about papers or science anymore, just some fun things. So the first one is tell us something fun about you that most people don't know.
Um, a fun fact, I did a 24/7 urgent care coverage in a resort before over a month. And um, that was one of the best time of my life, of course. But I think I learned very quickly that the resort fancy life, towards the more time you spend in it, the more becomes just an expectation and it fades very quickly. And really, um, life is more about the challenges in it than the facilitated, easy, fancy life you live.
Yeah, I'm really into travel and resorts. What can you share the name of the resort that you were at?
It was in the Red Sea in Egypt, where I grew up.
Okay, great.
Very interesting. If you were not in medicine, what career do you think you would have pursued?
Probably architecture. I feel like I'm an architect by, like I'm a curious and core architect that like just to solve problems.
Yeah, we also have a love of architecture. We built a home together with an architect, and just whenever we go anywhere, we look at the way buildings are designed. So, really like that as an answer. If you go back and give advice to your younger self, what one piece of advice would you tell yourself if you could?
Um, be patient and don't have regrets because the data you have tomorrow, you didn't have yesterday when you made the decision.
Wow, I really like that. Okay, one more. What's one lesson you've learned in medicine that also applies to life?
It's medicine is never white or black. It's always gray, and life is always gray as well.
Wow, that's a
Just different shade.
great way to finish the podcast.
Yes.
I find that the greatest physicians that I have ever seen navigate well through uncertainty, the gray zone that you described. So, thanks for all those pearls of wisdom. Um,
We
for our,
really appreciate you
yeah,
being here
it
today.
was
Thank you so much.
great having you on. Now, if for our listeners, if you wanted a deeper dive on some of the topics that John covered today, he's going to be speaking at our conference, giving the update for 2026 on the most important papers on AI and infectious diseases. And I love the depth at which he goes into these studies. It's like the real deal. So hope you'll come to Chicago and hear John teach us about all that's new in AI and ID and informatics as well.
Thank you again for having me.
Thank you, Jeff.
We hope you enjoyed this episode of the AMCAIM podcast. To learn more about the college, visit our website at www.americancollegeaim.org. Also consider attending our annual scientific session this fall in Chicago at McCormick Place. Thanks for listening.